Hey everybody, we are on to part two of the cardiovascular system, looking specifically at the vessels, everything downstream from the heart, what happens when the blood leaves the heart. So here's a snapshot of the different types of vessels along the journey here. The main vessel leaving the heart is the aorta, and the aorta will split, the fancy word is bifurcate. The aorta will split and then it'll split again, and there will be lots of branches, and very similar to how different exits would be found off of a freeway, and they would lead to highways and county roads and eventually smaller streets and residential areas. Very similar in the cardiovascular system. You have branches coming off of the main conduit and perfusing smaller regions. So you'd have large arteries coming off, and then those would branch and branch again and branch again into small arteries. And then the smallest of all of the arteries are called the arterioles, and the arterioles will then perfuse the capillaries. The capillaries are not really an artery or a vein. They are this intermediate zone that acts as the place that's where all of the capillary exchange is happening. So any cell in your body, there's capillaries everywhere in your body. We talked about in the blood chapter, they can be about 7 micrometers in diameter, so they're very small. And generally it's the case that any cell in your body, whether it be in your liver or your heart or your brain or your stomach, any cell anywhere in your body, is likely that it won't be more than a couple hundred microns away from a capillary. Capillaries are the place where nutrients are being delivered and wastes are being extracted. Capillaries have very thin walls, so things can get into and out of them more easily than something surrounded with muscle like an artery or a vein. The capillaries, there's different types of them. They all vary in how permeable they are. Some are very permeable, others are not so much. But they all, regardless of the type, they all allow fluid to pass through. So water can get into and out of the capillaries. And then also any dissolved substances, so like electrolytes like sodium ions, potassium ions, chloride ions, or vitamins, or amino acids, or other nutrients, they can get into and out of the capillaries. Proteins are variable. Some proteins that are very small, just a couple amino acids long, very small polypeptides, they can get into and out of capillaries, but generally it's the case that proteins are not able to get into and out of the capillaries unless it's a special kind of capillary called a sinusoid, and those are only found in a few spots in the body. Okay, but this is where life is really happening. It's all about the capillary bed. That's where there's the great exchange happening between cells and the life-giving substance of blood. All right, then once we get on the distal side of the capillary, now we're talking about the smallest of the veins, which is called the venule. So now we're actually going back to the heart. The arterial system, remember, arteries carry blood away from the heart. The venous system carries blood back to the heart. So the venules are the smallest of those veins, and then we get into smaller veins, and then lastly the vena cava are the big, they'd be like the analogous to the aorta, but on the venous side they're the big conduits that bring blood back to the heart. Remember, you have the superior vena cava and the inferior vena cava. The inferior vena cava runs all the way along the vertebral column, all the way up and down your trunk, and that is true also of the aorta. Now, what's interesting about veins is that these are low pressure systems. So if you were to look at, let's say, this is like the average blood pressure. When we're in elastic arteries, so that would be something like the aorta, you were to put a transducer in here and measure the blood pressure, it would be about 100 millimeters of mercury, measure of pressure. By the time you get to the arterioles, the pressure has dropped some. So now we're like more like 60 millimeters of mercury. By the time you get to the venules, we're more like 20 millimeters of mercury. And the reason why the pressure is dropping, a couple of reasons. One is we lose a little bit of energy due to friction against the walls of the vessel as the blood flows through. But the largest bearing on pressure has to do with the size that the fluid is occupying. So if you were to look at the average cross-sectional area, let's say, of all of the arteries, if you were to take a cross, what I mean by that is you were to like think about all of the space that the fluid is going into. The more this vessel branches, the more space there is for it to occupy. And so when we get to arterioles, there's tons and tons of arterioles. So when you think about blood like leaving the heart and going into the aorta, the ventricles just contracted and a large bolus of blood has entered the aorta. It's only occupying this cross-sectional area. It's only occupying this space of the tube. But by the time that bolus of blood branches and perfuses and gets to the level of the capillaries, there's tons and tons and tons of capillaries. So it's a much larger container for the blood to occupy. And anytime you put a amount of blood or any fluid into a larger container, it exerts less pressure on the walls of the container, so the pressure is less. So we are losing pressure as we go down the tube, and that just has to be the case because of the way that you have to have vessels going to every part of your body, right? You started with blood going through one vessel, and then that has to get to all the nooks and crannies of your body, so you're going to lose pressure. The greatest pressure drop, you can see it, a major inflection point here in the curve. The biggest drop happens across the capillaries, again, because that's the biggest opening. That's the greatest change in the cross-sectional area. And then by the time we've made it through, and we've actually lost some fluid out of here, actually, we'll talk about that in a minute. But by the time we made it through, we only have 20 millimeters of mercury left. So I had, I started with 100, and I had up to the capillary bed, or across the capillary, I lost 80 millimeters of mercury, right? I started with 100, and by the time the fluid passed through the capillary, I'm at 20. So there's a change of 80 millimeters of mercury here that drove that fluid flow. Well, now I have to sort of make the same journey back to the heart, but now when you get back to the heart, it's about 5 millimeters of mercury. So that change is only 15 millimeters of mercury. So you see what I'm saying here? There's the greater the pressure gradient, the greater the flow. And I've got a strong pressure gradient, 100 at the top, 20 at the bottom. But on this pressure gradient, bringing blood back to the heart, I'm starting with 20, and I end up with 5, so I'm only changing 15. The gradient is not as steep. There's less of a change of pressure. And so that's going to be a problem for fluid flow. For fluid to flow, it has to go from a high pressure to a low pressure. And the steeper the gradient, the more forcefully the fluid will flow. So there has to be something that helps us out. There's a couple of things that help venous return back to the heart. One is that the veins are usually a bigger vessel. There's a bigger cross-sectional area, so there's going to be less resistance, so fluid can flow more easily. So we can maybe make a little note here. What are some of the things that help venous return? The veins are bigger, okay. 2, there is negative pressure, actually, that's like a vacuum that sucks the fluid back in. Every time you breathe in your lungs, there's a slight negative pressure that is created there, and it acts sort of like a little vacuum to suck the fluid back up into the heart from the thoracic cavity. Okay, another big thing that helps is that the veins have valves in them, and that is special. Arteries don't have valves in them. So we're seeing a nice cross section of, let's say, a big vein that's passing into the middle of, let's say, your gastrocnemius muscle, your leg muscle. Well, when your muscles contract, they push down on the vein, and it squeezes the blood up. So I guess this works in combination with contractions of the muscles. And this would be skeletal muscle. So muscle that you can actually contract on your own volition. Okay, so when your muscles contract, it pushes the blood through the valve, and any blood that escapes there, even though it's going against gravity now, it's going from your leg back up to your heart. So gravity is pushing down on it. That's another barrier to it. But the valves help any blood that has made it up to the next tier from coming backwards down below. So with all this rhythmic contracting of the muscles, it pushes the veins up and up and up each tier, and each tier new tier that it makes it to, the valves will not let it give way, and it won't return back. So a couple of things about this. Every time you stand up, you feel the pressure of gravity pulling blood away from your heart. When you're laying down, venous return can happen a lot more easily because it's not working against gravity. And this is one of the reasons why we faint. A big reason why we faint is because we have a low blood pressure. That could be because you're dehydrated, or because your muscles are getting weak, and so they're not pressing against if you've been standing for a really long amount of time, the muscles are getting weak, they're not compressing the fluid and pushing it back to the heart. Either one of those things can make you feel lightheaded, and generally the mechanism there is that you would faint. Well, fainting is designed to get you lying supine, or get you lying vertically or horizontally, so that you're no longer overcoming gravity, and then that will allow venous return more easily to the heart. So even if you have a low blood pressure because you have low blood volume, that blood can still make its way back to your heart and keep circulating through the system. Blood tends to pool in your legs and in your feet because that's where gravity's pulling it. And this is another reason why getting out there and exercising is really a good thing. Just walking a few minutes now and again can help venous return back to your heart. It can help to squeeze these muscles and send blood back to your heart. And that all, the rhythmic pumping of your muscles with the valves and the vacuum that's established in your thorax, and then also the greater cross-sectional area of the veins, those all help to encourage venous return back to the heart, despite the fact that we've lost a lot of the pressure in this whole capillary exchange thing that we're going to talk about next. Okay, now blood pressure then is important metric for health, because if we lose the blood pressure, we lose perfusion, and that would result in ischemia. Blood pressure is very important to regulate. Your body will work very tirelessly to regulate your blood pressure. A standard blood pressure is what's called 120/80. And we'll talk about what those numbers mean in just a minute. And your body will work to try and maintain this. If you have a blood pressure that's higher than this, it would be called hypertension. If you have a blood pressure that's lower than this, it would be called hypotension. And your body wants to keep a high blood pressure, but there's kind of a balance here. If your blood pressure is low, it makes it easier for the heart to work, actually, to some extent. There are animals that operate on a low blood pressure system, like fish use a low blood pressure system. But we use a high blood pressure system. It takes more energy to pressurize the system. It takes more effort of your heart to maintain a high blood pressure system, but a high blood pressure system helps to make it such that your fluid flows more efficiently. When blood flows through the capillary, it flows well because there's a high pressure. It's all about the pressure gradient. But it's sort of a balancing act. If the pressure is too high, then now your heart has to work harder. Every amount of pressure that you add to the system, the harder your heart has to work. So there's this balancing act. You want the pressure to be high enough that it drives fluid to flow well, but too high and it's unnecessary strain on the heart. So a pretty optimal level is 120/80. We'll talk about what that means now. Okay, when your heart beats, it oscillates. If I was to if I was to put a pressure transducer, let's say, on your brachial artery and measure the blood pressure passing through it, I would see it oscillating. It'd go up and down and up and down and up and down and up and down and up and down. And the reason for that is every time your heart contracts, so here's your heart, and let's say this is your aorta coming off of it, there's a bolus of blood, all this blood in the ventricle, it gets pushed into the aorta. And that's going to cause distension of the walls of the vessel. These are elastic arteries, so they're stretchy, and all that blood then has room to go in and be absorbed. And it's going to cause an increase in the pressure as the bolus of blood is passing through. So that's what this spike is here. As the bolus of blood passes through, the pressure spikes, and then after the bolus of blood passes, the pressure falls. And then once the heart contracts again, the bolus of blood passes through, the heart pressure increases, and then as the bolus passes, now it relaxes. Well, at max pressure, we call this the systolic pressure, because it's the pressure in the blood vessel when the heart is in systole or contracting. And then when the heart, after the bolus of blood has passed through, there's still fluid in there, and the fluid will exert pressure on the wall, and the arterial system is pressurized. So there will be a pressure in there, and that's called the diastolic pressure. In other words, the pressure in the blood vessel when the heart is in diastole. So when you take somebody's blood pressure and you get a reading, let's say, of 120/80, the top number is the systolic number, and the bottom number is the diastolic number. So in other words, the top number tells you what the blood pressure is when the heart is contracting, and then after the heart is relaxed, what's the pressure still in the vessels. Generally, anything in the range of 140 or higher is hypertension. And another thing that's really important, like you can have a systolic pressure of 120, or sorry, a systolic pressure of 130, 140, 150, 160, well, maybe even 180. And that would mean that your heart is working harder than it has to. But it's still okay, because the higher the pressure, the better the fluid is going to flow. And so, the higher pressure just means more efficient blood flow. Your heart's working harder than it has to, but it's still giving you some really nice, efficient flow through the cardiovascular system. When there's a problem is the diastolic number. So the diastolic number is a problem because if we remember back to what we were saying earlier, you have the aorta here, and let's say that this is 80 millimeters of mercury. When the ventricle contracts and the blood has to eject out of the aorta, it has to overcome that 80 millimeters of mercury. This is called the afterload pressure, this pressure in the aortic arch here. It has to overcome that. And the more elevated that this is, the harder the heart has to work before even any fluid could flow. So like if you had a blood pressure, let's say 150 over 70, it means you are getting great perfusion through your tissues, and it also means that your heart is not having to work very hard to provide that perfusion. If this was 70 here, the heart has to only overcome 70 millimeters of mercury of pressure before the fluid will leave and pass through. If this was, let's say, like 110, that means your heart has to overcome 110 millimeters of mercury before any fluid will flow. And now that means you're not getting as much fluid flowing, and your heart is having to work really hard for that fluid to flow. So clinicians would be really concerned about the diastolic number. And if this starts to approach closer to 120, that can be a real problem, and you would want to go to the hospital. You can start to stroke out at about 120 millimeters of mercury diastolic pressure, and so this would be a cause for concern if this was getting closer to that 120 number. I have really high blood pressure. It's really common for me to have like 150 over 105. My record is 220 over 120. When I was in a super stressful situation. So that can happen, and some of the reasons why this would be elevated. One is stress. When your sympathetic nervous system is working, it tends to cause vasoconstriction, so the vessels constrict, and it's harder for fluid to pass through when the vessels are constricted. And so it would mean there's a greater afterload pressure, a higher pressure the heart has to maintain in order for fluid to flow through those constricted vessels. It could mean that there's stenosis of a vessel, so sometimes calcified crystals or fatty plaques can build up in a vessel and cause obstruction of blood flow. And if it's in the aorta or if it's in the renal arteries, it can be problematic because the kidney is one of the things that reduces your blood volume. If your blood volume is too high, that can lead to this happening too. The more fluid you put into the vessel, the more pressure it's going to have. So if there's anything going wrong with your kidneys where they can't remove the fluid, then it can build up. So yeah, so obstruction of the vessels, maybe even blood clots obstructing vessels could cause this to elevate, and that would be all cause for concern. There's different medications that are used to treat hypertension. They're probably one of the most commonly prescribed medications. One I can think of is losartan, and losartan, what it does is there's a mechanism the body uses to get rid of fluid out of to conserve fluid in your body, and that losartan sort of puts the brakes on that mechanism and allows you to lose more fluid than you normally would, and to lose fluid, then that helps. There's another class of drugs, diuretics, that help you to pee more, and so that's the same idea. They help you to lose more fluid to try and reduce that diastolic blood pressure. Okay, so lots of clinical applications here for blood pressure. It's a really common metric. One of the most common things that will cause your heart to fail earlier in life. Heart failure is one of the #1 killers in the world, and a chronic hypertension will be one of the things that puts the extra strain on the heart. And so this is why exercise, like even just 20 minutes a day or 30 minutes a day, chronic exercise is so important for a couple of reasons. One, exercise causes vasodilation of your vessels, so it opens them up and allows the blood to flow. It puts, it gives you a nice strain. It alleviates the strain on your heart. When you exercise, your muscles release vasodilatory factors that cause vasodilation of the vessels, and greatly are going to lower that diastolic pressure. And also, it strengthens your heart, and having that blood flow at a higher blood pressure can also help to sort of clear out the vessels. To get that good perfusion is important. Exercise is also important because it avoids the depositing of plaques on your arteries. When you're sedentary and you don't move a lot, it's easier for fatty plaques and things to build up on your vessels. And when you have plaques building up in your vessels, it blocks fluid flow, and it can cause higher blood pressure. And those plaques are very difficult, and it may be impossible to get rid of as soon as they build up and accumulate in your arteries. So the more you can do to exercise regularly now, and to not gain too much weight. Weight gain is another thing. And the fat from weight gain can press on your vessels and make it harder for fluid to flow. That's going to increase your heart rate. So exercise is really important in terms of alleviating the strain of your heart, prolonging the life of your heart, and therefore prolonging your life. And it doesn't take much. I mean, they say 20 or 30 minutes a day would work wonders. So you know, if you're not somebody that does a lot of exercise, I would highly encourage you just to put on your walking shoes and take a 20 or 30-minute walk daily. And I think you'd be amazed at how good you feel after a few months of doing that. Okay, now it is such an important thing to measure. How do we measure it? We use this device called a sphygmomanometer. Say that 10 times fast. It's basically just a blood pressure cuff. Sphygmo means flow, manometer means pressure meter, and this is a pressure meter that uses principles of flow to work. So we call it a sphygmomanometer. Here's how it works. What you do is you put the cuff on the patient, and you will turn the valve on here so it's shut, and you'll squeeze the ball, and the ball is going to inflate the cuff. When you inflate the cuff, you know, if I was to draw a really poor picture of somebody's arm, okay, there's somebody's arm. Okay, there you have, okay, 5 fingers, good. All right, here's their arm. They put the cuff on like this, and the cuff is going to press down on their arm, and it's going to block the brachial artery, actually. And then what's done is a stethoscope is placed right over here, just you know, on the medial side of the antecubital fossa, your little elbow pit there. That's where you can get a pretty nice listen of the brachial artery. So you put the stethoscope right on that brachial artery. You block it by inflating the cuff, and what you want to do is you want to inflate the cuff so that the pressure in the cuff is higher than the systolic pressure in the brachial artery. When that's accomplished, it totally seals off the artery, and it will not at any point be open. So if I was to draw this, you know, on a graph, let's say this is your heart rate, this is your heart beating, and this is the pressure in your brachial artery. You want to get the pressure in the cuff higher than the systolic pressure, because at that point the vessel will be totally closed, and you will not hear any blood whooshing through it at all with the stethoscope. Then what you do is you release the pressure in the cuff. So there's a little dial here, and you just slowly turn it, and you'll see that the pressure meter starts to fall because the pressure in the cuff is air is escaping, and it's going down. Okay, so then the pressures start to fall, start to fall, start to fall, start to fall, start to fall. Now at a certain point, the pressure in the cuff is going to be just below the max systolic pressure in the brachial artery. And when that happens, for just a moment, only at the peak of systole will you get this sort of situation going on. Imagine this is the brachial artery here I'm drawing. And it's the brachial artery just downstream of where we've put the cuff. So like, you know, here's your stethoscope is above the skin, you know, just above the brachial artery. This is a really bad drawing, but here's your little stethoscope, here's your skin, here's your tissues, here's the brachial artery. Okay, just downstream of the cuff then, only at the max of systole, will there just be enough pressure to open up the vessel, and you know, the cuff is pushing down on it, but just in systole there's enough pressure pushing back on the cuff that it opens momentarily and allows blood to squirt through. Well, when that happens, there's turbulence here that happens because of I think it's called the Bernoulli effect. You have blood whooshing as it squirts through that bottleneck. Well, you can hear that turbulence in your stethoscope. That's why this is called a sphygmomanometer, because you're based upon the flow, the whooshing sound that's made when the blood flows through rapidly in this bottleneck. You can hear that. And so the long and the short of it is that as the pressure in the cuff is decreasing, as soon as the pressure is less than the max systole, now we've got the bottleneck, now we have the whooshing, and now you're starting to hear in your stethoscope the whooshing noises every time the heart beats and is in systole. It just sounds like whoosh, 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 whoosh. Okay, so now the pressure in the cuff is still decreasing, decreasing. You're hearing the decreasing, decreasing. Eventually, the pressure in the cuff is going to be less than that of diastole. And at that point in time, if I was to redraw this, the vessel is always open. It's never bottlenecking at all, because there's no point at which the pressure in the cuff is pressing down to an extent that can close the vessel. And so now the sounds go away because there is no bottleneck. So when you're taking a blood pressure, if you don't understand the physics behind it, it's fine. When you're taking a blood pressure, basically what you do is you inflate the cuff so it's sure to be above systole. You let the valve open, the air escapes slowly, and you listen. And as soon as you hear the sounds, you mark it. That's your systolic pressure. As the pressure in the cuff continues to decrease, as soon as the sounds go away, that's your diastolic pressure. Those, for whatever reason, they're called the sounds of Korotkov. The sounds that you hear as the blood whooshes through. Okay, now let's talk about the capillary bed. This is where life as we know it is happening. This is where the cells are getting what they need and getting rid of what they do not need. I call it the great exchange because it is the place where the vessels are permeable enough to allow things to get into and out of the blood. Okay, this is an illustration of a standard capillary bed. What you're seeing here is this is the arterial side, and this is over here the venous side. Blood is coming from the heart down through the arteries into the smallest of them, which is the arteriole. So an arteriole, not to be confused with arteriole. Okay, arteriole is the smallest of the blood vessels that are on the arterial side. This over here would be a venule, the smallest of the veins. Okay, how it works is there's what's called a met arteriole, which is going to be an arteriole that sort of goes halfway in and provides a thoroughfare for the blood. So blood can always be passing through a capillary bed, and it can bypass it if it needs to. In fact, often it's the case that blood is bypassed through capillaries if the cells are happy. By the way, if I was to draw them, your cells would be living in the capillary bed like this. So it's very similar to like how houses are in a neighborhood. You can think about the cells being the houses, and the streets being like the capillary. And the same way you get things to and from your house through the streets, you get things to and from your cells through the capillaries. So there will be capillaries surrounding these cells surrounding these capillaries. There's never a cell that's more than a couple hundred microns away from a capillary. A typical cell is about 100 microns in diameter, so there's never going to be more than like 2 or 3 cells stacked next to each other before there's a capillary that can perfuse it. So tons of capillaries. The mind-boggling statistic here is you have like 60,000 miles of capillaries in your body. If you were to take all the capillaries, line them up end for end, it's like 60,000 miles. It's amazing. All right, so blood can bypass a capillary through the thoroughfare, through the met arteriole. But let's say a bunch of these cells in this quadrant right here were starting to become acidotic. They were starting to require oxygen. They wanted to get their mitochondria fired up to make some energy. Well, what they would do is they would release a vasodilator, and a very common one is nitric oxide. So there's a protein in cells called the nitric oxide synthase, and it makes nitric oxide. And nitric oxide will accumulate, and it will bind to the smooth muscle here in what are known as the precapillary sphincters. These are a major gateway to govern perfusion of tissues. If the sphincter is closed, the cells will not receive oxygen. If the sphincter is open, blood will pass through now and deliver to the cells. Blood does not continuously perfuse all the capillaries in your body at once, but rather what happens is it's perfused in an intermittent fashion. So the capillary will open, blood will squirt through for a while, and then the capillary will shut. This is called vasomotion. blood's always intermittently squirting through different capillaries for a moment, and then it stops. You only have about 6 liters of blood in your body, and that's not enough to pass through 60,000 miles of tubing at the same time. So the workaround is that it squirts through intermittently, and cells do not always need continuously oxygen. They just need it for a while. So the cell might take in a bunch of oxygen and then go through aerobic respiration and make some energy, and then need some more, so take in some more. So your cells are always calling for oxygen, and then stopping that call, and then using the oxygen, and then they call for more, and then they don't call for more, and then they call for more, and then they don't call for more. It's this constant flow of fluid through the capillary beds. Okay, now there is also usually a big shunt that's different than the met arteriole. The met arteriole is sort of a thoroughfare that passes through, that's going to be mostly open. So blood is always at baseline, sort of trickling through the capillary beds. It doesn't require nearly as much volume for it to passively flow through here, because it's, there's not nearly as much cross-sectional area as the entire capillary bed. Another big shunt, though, if we really need to shunt blood away from a region that doesn't need the oxygen and doesn't need the blood, is there's a vessel that usually connects the two, which is called an anastomosis. Anastomosis is any vessel that's used to connect between two places. But this one is connecting between the arterial side and the venous side, so it's called an arteriovenous anastomosis. And it's a major shunt that the blood can pass away from. Often capillary beds have collateral arterioles going to them, so there might be more than one arteriole that leads to the capillary bed, and that's sort of a defense mechanism or a safety mechanism. If one, if one arteriole gets blocked for whatever reason, there might be other pathways that blood can flow to the capillary bed. And I often think it's cool to stop and appreciate how this is all constructed. Your cells can release factors that cause the construction of these capillaries, and if a region of your body is damaged, the cells can repopulate it and reestablish these networks of roads by calling for that factor. It's really pretty cool. Okay, so here's an image that shows sort of vasomotion. This is passing through an arteriole, but it could be even like an arteriovenous anastomosis. You can see that the arteriole opens, blood flows through. The arteriole has smooth muscle wrapping around it, and when that smooth muscle is relaxed, the arteriole opens and blood rushes through. And then once that smooth muscle constricts again, it shuts it off. So this intermittent squirting of blood through, we call it vasomotion. A lot of tubing, a lot of plumbing going on here in the human body, which is really just fascinating. I think it's difficult to get, the infrastructure is difficult to get things and distribute them around throughout the body, and just the distribution capabilities of the body are amazing. All of these networks, all of these roads through which things can be delivered to the cells that are all constructed by the cells for the cells. It's pretty fascinating. Okay, now let's talk about capillary exchange. We said, about 60 millimeters of mercury here of pressure in the fluid that's here, about 20 millimeters of mercury over here. There's a lot of pressure exerting on the walls of these. There's 60 millimeters of mercury of pressure exerted on the walls of these capillaries. Well, these capillaries are permeable. They allow fluid, they allow water out. Okay? So water comes out, and it also with it some electrolytes, ions, and things will come out on the proximal end. And they say for the average person, if you were to figure out how much fluid is lost across the entire capillary network of all the capillaries in a given day, they say it's about 24 liters of a day that you lose, 24 liters of fluid that you lose out of your blood and into the surrounding tissues. Now, by the time we've lost that 24 liters on the distal end of the capillary, the hydrostatic pressure is not so great. You know, we started off with 60 millimeters of mercury pressing against the walls. Now we only have 20. Here, it's sort of the reverse story. The fluid that's in the cells has more pressure than the fluid that's inside the vessel. You've just given the cells and the tissues a bunch of fluid. Now that tissue is somewhat distended, and so it actually wants to push the fluid back to the vessels. And it does come back. There's about 20.4 liters a day that return back into the capillaries. So you have this continuous microcurrent of fluid washing the cells. You have fluid that leaves on the proximal end and it returns on the distal end. The fluid leaves and comes and leaves and comes. This current, these microcurrents of fluid bathing the tissues. And that's really important because it helps to distribute and disperse through diffusion nutrients to the cells. It also helps to wash and collect waste from the cells. It also helps to wash the cells and collect any type of pathogen, viruses, bacteria, anything that gets in here. It can wash and collect back in. Okay, now here's the question. You have lost 24 liters a day in your proximal sides of your capillaries. You've only reclaimed 20 liters a day, so what happened to that other 3.6 liters? You're not always losing 3.6 liters out of your body each day. You only have 6 liters of blood, so it'd be really bad to lose 3.6 liters of that. So what happens to this 3.6 liters is that there's another network of vessels in here, which are called the lymphatic vessels. You have these sort of branches of lymphatic vessels that start in the capillaries, and they have little small micro valves in them, and the fluid can seep in through the terminals of the lymphatic vessels. And then that 3.6 liters becomes the lymph. That extra fluid passes through, and it's easier for fluid to get into these than it is, let's say, to get into the distal end. These are more permeable, and so they let more things in. So if there was something like a virus or a pathogen, a bacterium, or even a parasite, it would more readily be absorbed by the lymphatic vessels than it would the distal end of the capillary bed. So this is where the real washing of the tissues does occur, is the lymphatic system, because if a pathogen gets, is in the body and it gets swept up through the lymph into the lymphatic system, from here, the lymphatic vessels are going to shuttle it across a lymph node to another lymph node to another lymph node, and then finally it will pour back into the heart. So this 3.6 liters does in fact return back to the heart, but it does it after passing through a whole series of lymph nodes. And lymph nodes are like the major checkpoints that screen your body for pathogens and help to mount an immune response if one is found. Okay, a major clinical application of this is what's known as edema. And edema just simply means swelling. And why this would occur is something to do right here with this whole process we're talking about. Edema can result for a couple of reasons. One, it can result because the blood pressure is too high. When you have a high blood pressure, the rate at which you lose fluid on the proximal end is greater than normal. And so you might, instead of losing like, let's say 24 liters a day, maybe instead you're losing like 30 liters a day, but you're still only reclaiming 20 liters a day, and you're only still reclaiming in the lymph 4 liters a day. So now you actually have fluid that's not making its way back to the heart via the lymph or the venous system, but it's accumulating in the tissues. That water leaves and it stays. Well, that's when swelling is evident, and that's edema. Really common times that this can occur. It happens anytime you have inflammation. When you have inflammation, the vessels become more permeable, and so you'll lose more fluid out anyways, because now the vessels are more permeable. Some of the factors that are released during the inflammatory response, they cause the vessels to be more permeable, and so you lose more fluid than normal, and you will get swelling. Anytime you have inflammation, you have swelling. Another reason, though, that this could occur, like this is very common, it very commonly happens in pregnancy. Women who are pregnant, they have like a 50% increase in their blood volume. And because of that increase in their blood volume, they're going to have a greater blood pressure. And so it leads to more fluid escaping. And you see this more common in the feet because the blood pressure is highest at the bottom of the column of gravity. You know, think about your body being like a big bag of water, and similar to like how there's greater, you know, pressure at the bottom of a tube of fluid, there's more pressure at the bottom of your tube of fluid in your cardiovascular system. So blood tends to pool in the feet already, and when you increase the blood volume, that effect is magnified, and you generally get swelling in the feet, and this is very common in pregnancy. You would also note this in if you go on an airplane. You know, if you go on an airplane, it reduces the venous return to your heart. You're sitting for so long, and when you're sitting, you're not contracting your muscles in your legs, and so the blood just sort of pools. It distends the vessels, and the blood pools in your leg, and that can lead to a swelling in the tissues of your body, specifically in your feet and in your ankles. You know, in that situation, it's almost like, if we go back here to this diagram, it's almost like because of the decrease in venous return, there's sort of a backlog of fluid here, and so there's less of a tendency for fluid to come back in on the distal end because they've got all this fluid downstream from it. You know, there's a greater pressure probably in the venous side. So that can happen when you go on an airplane. Other reasons for edema, there can be lymphedema, and this would be a situation where the lymphatic vessels are blocked, and so that 3 or 4 liters a day, which would normally return via the lymphatic vessels, it does start to accumulate in the tissues, and this can cause major swelling. If you were to look at a person with lymphedema, like usually what it looks like is their whole leg is swollen. There's way too much fluid in all of the tissues, and like their leg could be two times the size of normal. That would be because of a blockage in the lymphatic vessels. Okay, all really important stuff that you would see often in the clinic pertaining to the heart and the cardiovascular system. But again, just stop and appreciate the fact that your heart, you know, this wonderfully designed pumping blood through 60,000 miles of tubing to deliver to each and every one of your cell the nutrients that it needs. I mean, it's nothing short of amazing. I mean, it's think about trying to keep a whole city of people happy with the supplies that they would need. It's a very difficult feat. And think about your body being a city of trillions of people, trillions of cells, and your body having to keep trillions of cells happy with the supplies that they need. Your cells are always active. They're always building things and making things, and they always need the substrates that fuel those processes, and it has to be delivered via the blood It's a major infrastructure. And there's a lot of places that it can go wrong, and it's a major diagnostic focus for health is your heart working properly? That is most easily assessed by your resting heart rate and also your resting blood pressure. All right, that's going to wrap us up for the cardiovascular system.